I'd like to thank the Pedirhythm organizers for allowing me to speak on Timothy syndrome. I do have a disclosure. I am not a Timothy syndrome expert. I've only seen a few cases, but I know Catherine Timothy. Timothy syndrome is named in honor of Catherine, who was pivotal in the phenotypic characterization of the syndrome and remains a champion for these children. A lot of what we know about long QT syndrome and Timothy syndrome can be traced to these three people. And in 1991, in Utah, where I'm from, the history of long QT syndrome discovery begins. But the first case of Timothy syndrome is actually in the German literature. It's a single case report from 1992 of a baby born preterm at 36 weeks gestation by C-section with intrauterine bradycardia. This is a theme that will continue throughout this talk. Postnatal ECGs demonstrated second-degree block. He had syndactyly of the hands and feet. Presumably this means a long QT interval and sudden death at 5 months of age. A few years later, we returned back to Utah. In 1995, Mindy Marks and Mark Keating add to the literature in this case series of 3 children with profound QT prolongation and syndactyly. These children also had congenital heart disease and, again, early onset of symptoms in fetal and neonatal life. A second case series from the same group expands the population, adding 5 patients and speculating about the likely de novo inheritance pattern, and commenting that children with syndactyly should be screened with an ECG, a practice our hand surgeons have adopted. Igor Splowski is a scientist, or was a scientist, in Mark Keating's lab, and in this cell population quotes the Nobel laureate Otto Loewy about the importance and ubiquity of calcium. For the first time, this syndrome is called Timothy syndrome. This paper relates the discovery that this is a gain-of-function mechanism mediated through failed calcium channel inactivation. Here, for the first time, they identified a missense mutation in exon 8A of the L-type calcium channel, important for excitation, contraction, coupling. This was back in the day, and they performed functional expression of mutant and wild-type channels in heterologous systems, demonstrating that the causative mutation G406R leads to nearly complete absence of voltage-dependent channel inactivation, resulting in inward calcium currents and intracellular calcium overload in multiple cell types. This is called long QT 8 because it was the 8th identified. It involves 17 children who demonstrated in this paper molecular homogeneity. All also had fairly phenotypic homogeneity with QT prolongation, syndactyly, abnormal teeth, and were born bald. Most had arrhythmias, including bradycardia, AV block, torsade, and ventricular fibrillation. 10 of 17 children died at an average age of 2.5 years. Features included congenital heart disease, dysmorphic facies, recurrent infections, intermittent hypoglycemia, developmental delays, cognitive impairment, and autism. 1 year later, the same group characterized 2 children with an even more severe form of Timothy syndrome that we are now calling Timothy syndrome type 2. They were without syndactyly but had even longer QTC intervals and more cognitive impairment. In these 2, the missense mutation was in exon 8 of the CAV1.2 channel, again causing nearly complete failure of calcium channel inactivation. CAC and A1C gene has numerous splice forms. Gain of function mutations in CAV1.2 exons 8 and 8A cause distinct forms of Timothy syndrome. Timothy syndrome types 1 and 2 are distinct diseases. Voltage-gated calcium channels mediate calcium influx in excitable cells, cardiomyocytes, neurons, skeletal muscle, sensory cells, and endocrine cells, explaining the numerous organ systems affected in Timothy syndrome. Calcium entry via the Cav1.2 channels forms the action potential and is crucial for excitation-contraction coupling, and with significant effects on electrical and mechanical excitability and heart function. The heart's voltage-gated L-type calcium channel functions at a heterotetrameric complex composed of these subunits. Of particular interest is the alpha-1 subunit because of its physiologic role and the pathological consequences resulting from its perturbation. The alpha-1c subunit is encoded by CNA1C gene on chromosome 12 and consists of 4 homologous domains, each with 6 transmembrane segments. Cav1.2 channels are clustered near the ryanodine channel, forming the calcium release units, permitting optimal coupling for calcium-induced calcium release. And disruption of this relationship will give rise to calcium overload. Timothy syndrome is a gain-of-function mutation with at least 12 alternative splicing loci, producing about 42 mutants in different regions of the Cav channel. There's a wide variety of expression. Sustained depolarizing calcium influxes broaden the action potential, lengthen the QT interval, and lead to arrhythmogenesis. Genetic variants arising in this Cav1.2 subunit are implicated in a number of sudden death predisposing syndromes. Loss of function mutations have been associated with Brugada syndrome and early repolarization syndrome, and gain of function mutations in type 1 Timothy syndrome and long QT8, as well as cardiac-only Timothy syndrome. What about Timothy syndrome in the brain? Researchers created a knock-in Timothy syndrome mouse, and interestingly, although no homozygous TS mice survived, a heterozygous TS2 mouse was shown to have a normal outward appearance and survived to reproductive age. It was a TS2 neo mouse and likely survived because they lowered the G406R expression. These mice had odd, restrictive, repetitive behaviors, altered social behavior, and altered vocalization. And the researchers thought this suggested that when the Timothy syndrome mutant channels are expressed at low enough levels to avoid fatality, they are sufficient enough to cause multiple distinct behavioral abnormalities in line with the core aspects of autism. A few years ago, we identified an interesting Timothy syndrome patient. This was a male child born at 34 weeks gestation with fetal bradycardia due to 2-to-1 block. His postnatal ECG demonstrated 2-to-1 block and marked QT prolongation. He was born bald with subtle facial dysmorphisms and cutaneous finger syndactyly. He had a small VSD and decreased biventricular function. Genetic testing revealed a heterozygous 12-16G to A transition in CACNA1C, resulting in a G406R missense mutation in exon 8A, typical of Timothy syndrome. When discussing things with his father, the father admitted that he had cutaneous toe syndactyly. He had no other dysmorphic features and was cognitively normal without arrhythmic syndromes. His ECG demonstrated mild prolongation of the QT interval. Analysis of his peripheral blood DNA and buccal smear revealed a small A peak superimposed on a larger G signal at the position 1216 of exon 8A, suggesting he might be a mosaic in these tissues. And to further investigate this, we analyzed DNA isolated from his sperm and found the 1216G to A transition present in 16% of the sperm. I still follow this child, who is alive at age 12. He has an ICD, has undergone a left cardiac sympathetic denervation, and remains on Nadolol and magnesium. He's had numerous, somewhat eventful dental and syndactyly surgeries and has had numerous appropriate ICD shocks, but none since the cardiac sympathetic denervation. He expresses developmental delay, autism features, and speech delay. This was not the first case of mosaicism in Timothy syndrome. There were 2 siblings in the original series from ostensibly normal parents. Mosaicism is the presence of genetically distinct cell lines in a single individual, arising from a single zygote. There are tissue-to-tissue variations that may not follow Mendelian rules of inheritance. Gonosomal mosaicism, somatic mosaicism that occurs very early in development and is present in both germline and somatic cells of the mosaic individual, who may have subclinical disease, but who can have an affected non-mosaic child, as seen in our case report. In possibly the largest series to date, this multi-center study of 17 TS patients shows mortality is multifactorial, including ventricular arrhythmias, pulseless electrical activity, and hypoglycemia. The population is characterized by very young onset disease, very profoundly lengthened QT intervals, a high burden of hypoglycemia, and a number of genetic variants. Beta blockers proved to be not fully protective, and not all beta blockers were thought equal, and nadolol is the preferred agent. Most were treated with a combination of antiarrhythmic and device therapies. Mexiletine and the sympathetic denervation remain options. 70% of this population's events were associated with anesthetics or hypoglycemia. Hypoglycemia is due to potential episodic dysfunction of this channel in pancreatic beta cells, complicated by beta blockers, and we continue to advocate for patients avoiding prolonged fasting. Mean longevity in this population was 4.9 years. And this series expanded the TS-associated mutations within the CAC and A1 gene. In this 2015 document, the concept of cardiac-only Timothy syndrome was introduced. There was a complex phenotype, including long QT syndrome, hypertrophic cardiomyopathy, and congenital heart defects, as well as sudden death. None of these patients had syndactyly, cognitive impairments, facial dysmorphisms, or other non-cardiac clinical characteristics suggesting classic Timothy syndrome. Here are the 3 pedigrees of the patients in this cardiac-only Timothy syndrome cohort. This paper identified 2 novel, ultra-rare missense mutations shown here. Expanding the phenotype further, we identified a male baby at 59 days of life with a murmur. His ECG had left axis deviation and a QTc of 472. His echocardiogram demonstrated hypertrophic cardiomyopathy with significant septal hypertrophy and left ventricular outflow tract obstruction. His father, as part of his evaluation, had a screening MRI demonstrating hypertrophic cardiomyopathy at age 28, and then at age 30 had early onset atrial fibrillation. Multiple family members of this index patient had a variety of structural, arrhythmic, and conduction cardiac defects, as well as sudden death. The arginine 518 cysteine mutation in exon 12 of CAC and A1C gene was present in our index case, as well as 28 relatives. In addition to the cardinal features of the CAC and A1C disorders, long QT syndrome, congenital heart disease, hypertrophic cardiomyopathy, and sudden death, family members also manifested young onset atrial fibrillation and sick sinus syndrome. Typical long QT syndrome has an autosomal dominant inheritance. One parent passes the disease-causing variant onto their progeny. Timothy syndrome doesn't get passed on this way because of disease severity, and affected individuals rarely survive to reproductive age. De novo genetic variants present for the first time in one family member as a result of a variant in a germ cell of a parent, or variants that arise in the fertilized egg during embryogenesis. Since TS is such a harmful disease, likely most TS children acquire the variant de novo, or as a result of mosaicism. In the beginning, TS was a homogeneous disease, and we now recognize that there's incredible phenotypic variability among individuals with this mutation. Is this based on the timing and location of variants acquired, or is there a more complex genetic background that contributes to expressivity? When thinking about timing and location of embryonic de novo variants affecting cell lines differently, if an individual acquires a mutation, as shown here in the black arrow with the star, at the 4-cell stage, they may have abnormalities in all cell types. A variant acquired at the gastrula stage may only affect one germ layer and therefore have a more restrictive subset of cell types. And then a variant that arises after the germ cells have been set aside may only affect germ cells and not cause phenotypes in the individual, but that individual may go on to have an affected child. If all individuals with Timothy syndrome underwent whole exome or whole genome sequencing in relation to their parents or siblings, multiple genetic changes might be revealed that contribute to complex genetic profiles in this disease. But this is also likely true of many inherited diseases. Research is ongoing to help us better understand Timothy syndrome and find more effective ways of treating this highly lethal disorder. Researchers have created mouse models, but these do not fully recapitulate the human disorder, lacking the postnatal lethality that occurs in these patients. Recently, researchers generated human cardiomyocytes from Timothy syndrome patients using pluripotent stem cell technology. They examined contraction, electrical signaling, calcium handling, and performed drug tests. The cardiomyocytes created from TS patients exhibited deficits in contraction, electrical signaling, and calcium handling. And interestingly, this drug, roscotovine, rescued these cellular phenotypes. Roscotovine is a cyclin-dependent kinase inhibitor previously shown to enhance the Cav1.2 voltage-dependent inactivation in heterologous expression systems. Does this via direct extracellular binding, and it rescued the EP perturbations observed in Timothy syndrome iPS-derived cardiomyocytes. Agents with similar mechanisms of action may actually prove beneficial in the treatment of Timothy syndrome. So in conclusion, Timothy syndrome is a rare disorder affecting few patients, but multiple organ systems, with a more variable phenotypic expression than was originally thought. It is one of the more lethal forms of long QT syndrome and is lethal despite therapy. It is a very high incidence of young sudden death. It's due to variants in CA, and A1C that affects the calcium channel function. Voltage-gated calcium channels mediate calcium influx in excitable cells, cardiomyocytes, neurons, skeletal muscles, sensory, and endocrine cells. So you can see perturbations will affect a number of systems. Treatment options at present are poor, but are expanding, hopefully with IPS technology, and hopefully this will help us modify the lethality of this disease.